Good morning, everyone. Thank you for coming. It is my pleasure to introduce Professor Sarah Hawkes to DS. Sarah is a wonderful academic and an inspirational leader. On the academic side, some background to highlight. She's a medical doctor with a degree in sociology and a PhD in epidemiology. She is professor of global public health at University College London, UCL, where she leads a research team analyzing the use of research evidence in policy processes, in particular relation to gender and health equity. She has lived and worked for much of the past 30 years in different parts of Asia, and she is currently the co-chair of the Lancet Commission on Gender and Global Health. And I wanted to share, in addition to the bio that many of you have seen already, what I find most inspiring about Sarah is not just her rich academic profile, but her strong leadership and fierce belief in trying to shape policies in real life. She is the co-director and co-founder of Global Health 50/50, which advances actions and accountability for gender equality in global health. So this is a quote from the website that they have. Global Health 50/50 was born out of our shared frustration that despite evidence, change wasn't happening fast enough. Our academic outputs on gender and health were falling on deaf ears. Evidence alone, we knew, doesn't cut through the noise to change policy and practice. So we decided to change the rules of the game. For example, this year, their signature annual report reviewed 200 of the most influential global health organizations and their gender and geography composition of the governing boards. And they found that quote, the report warns that global health is not living up to its name. For example, they find that 75% of board seats are held by nationals of high-income countries, even though global health is global. 50% are from US and UK alone, and only 2.5% are from low-income countries. And women from low and middle-income countries make up 42% of the global population, but underrepresented in global health decision-making space, holding 9% of board seats. And during the COVID pandemic, GH 50/50 was the first to start tracking COVID data by sex, because you think just data by sex for cases and deaths of COVID would be a simple thing that WHO should be reporting, but they did not. And their data tracker received great attention from the media and policymakers, and it has led to other researchers and funding agencies interested in data reported just by sex alone. And lastly, I read a quote from a colleague that wrote about Sarah in a Lancet profile. Sarah engages in difficult conversations around gender equality. She has the unique ability to weave in evidence to tell a profound and impactful story in simple, lucid, and humorous ways. Sarah, the floor is yours. Thank you for coming.
Thank you very much, Angela. And first of all, a huge thanks to Angela and her colleagues for making this visit happen. And thanks to all of you for taking time out of your, I'm sure, incredibly busy days to come and listen to this talk, but more importantly, hopefully engage in a conversation about what I'm about to present. The quote that you just ended on is quite hard to now live up to, particularly the humorous part. So if you don't find anything humorous in the next 45 minutes, perhaps send a letter to the Lancet rather than to me. So as Angela said, I come from a multidisciplinary academic background myself, and as Angela has already noted, I have spent a lot of my career trying to bridge that gap that I'm sure many of you bridge between what we count in academia as evidence and actually then what has an impact or plays a role in how policies are made and programs are implemented in real-world decision-making processes and situations. And I've been interested in working on the question of how the global health community sees gender and what it understands by gender essentially for about the past 25 years. And as Angela has mentioned, that ongoing academic frustration led to us thinking about how to do things in a different way, how to communicate ideas in a different way. And so the content of my talk is actually going to be quite picture heavy rather than data heavy. And in my experience, pictures can often tell a story that actually is quite difficult for people who aren't as numerate as many people in academia might be, or not. That pictures can often convey what it is that we're trying to say. And I'm going to start with this picture because not the actual picture itself, but just to say that you'll see in the bottom right-hand corner that I've named the photographer. And the reason I've named the photographer is that as Global Health 50/50, which I'll come to in a short while, as Global Health 50/50, we've not only been trying to challenge or understand how the global health community sees gender, but also challenge how gender is framed within the global health community. And so one of the things that we do every year is run a photography competition. And so the photos that you're going to see are the shortlisted prize winners from the past couple of years of running the photography competition. And if any of you are budding artists out there, our competition is currently open. So I'd encourage you to go to our website and submit your visions. We've moved this year from This is Gender, was the title of the competition, to This is Gender Equality or Gender Inequality. So in this talk, first of all, you've just heard from Angela a bit about what I do, but just to encapsulate that, so I work as an academic in University College London. Usually if I say UCL, most people think that I'm talking about UCLA, but this is... We've got obviously a significantly worse marketing department than UCLA, but I am actually based in London, where I work in the Centre for Gender, Health and Social Justice. I work about half of my time on Global Health 50/50, and most importantly as an academic right now, I'm co-chairing the Lancet Commission on Gender and Global Health. And so in a kind of full disclosure, but also, I guess, playing on your empathy strings, most of what I'm about to present is actually the Commission's view, the Lancet Commission's view on what gender means for the global health community. It's been a huge struggle over 3 years to try to articulate what it is that we understand and think about gender within global health. I mean, part of that struggle has been we started the Commission in March 2020, which obviously rings lots of bells in everybody's memories. And we only had a chance to meet together as 20 commissioners in February this year because of travel restrictions. And what's happened in the ensuing 3 years, which again I'll come to later in the talk, is that gender has become a much more politically hot potato across geographies and particularly across generations. And so the ability to get a cohesive and coalesced vision of what we mean when we talk about gender in global health became actually much more contentious as time went on. But all of this is by way of saying that this is the first time that I've tried to present the Commission's vision of gender and global health. And that's why I started off by saying what I'd really like to do is engage with you, essentially for you to tell me what you think, for you to essentially to be the first sounding board as to what we've got right and what we've got wrong in our vision of gender and global health. So this just gives you an overview of what I'm going to talk about. So I'm going to talk about what we currently understand by gender and global health. What are the challenges in moving forward and what we think a revised approach looks like. So, I mean, it's very easy to go to the website of any global health organisation and see what they mean when they talk about gender in the global health space. It's probably more difficult, in fact, in a setting like this to define what we mean by global health than what we mean by gender. And I'm certainly very happy to have a discussion about what we're counting as the global health sector. But this, of course, comes from the normative agency within the global health space, the World Health Organization, and they've got a pretty traditional view of what gender means. And I know because I was part of the writing panel to come up with this definition, and it was an incredibly contentious definition. We started working on this in 2015. It's not just this one sentence. I promise you there's actually an accompanying page that goes with it. But that page went to every member state, went to every regional office, and provoked months and months of very fractious infighting as to what WHO could actually define as gender on its website. And it still is an unapproved, it's an unofficial definition, but it is the definition on the website. And you'll see that it's pretty innocuous and fairly meaningless, except within the global health sector, and I'll come to that now. What the Commission did was look at that definition and lots of other definitions of how actors within the system are understanding gender. And what we noticed was 3 entrenched biases common across not just these big organizations within global health, but certainly within the academic space in global health. And the 3 entrenched biases are, first of all, the conflation of gender and sex, people being simply unable to tell us, either on their websites or in their academic papers, what the difference might be between gender and sex. Conflation of gender to mean women and girls, or gender simply missing. Gender's irrelevant to the work that I do, and therefore I don't actually need to consider it in my work in any other part of the global health space. So I'm going to explore each of those in turn a little bit. First of all, thinking about gender and sex. So it's been an absolute pleasure and a real privilege over the past couple of years to work with Angela and another one of your colleagues, Virginia, on developing what we've called a health pathways approach to understanding disaggregated data in the health sector. And along that pathway, we've had this vision that what's often presented in global health is how many people have got a disease, or how many people die from a particular disease. Or if you're an economist in the crowd, you might think of health disaggregated, measured by DALYs, an econometric for understanding the burden of disease. But with the experience of COVID, as Angela talked about, we've actually been developing a conceptual idea that we need to think of health along a pathway from exposure to outcome. I mean, it's not rocket science, but it's definitely not been done very often in the global health space, as we'll find out as we go along. So there are bits and pieces of that data kind of wherever you look in health. Here's some gendered exposures in relation to tobacco smoking. This is data that we disaggregated for WHO about 5-6 years ago, using the global tobacco survey data. And we've analysed it by different age groups. On the top, you've got young people, aged 15 to 24 years. On the bottom, you've got all adults aged 25 to 69 years. And what we're seeing here is males in blue and females in yellow. And so even if you're not an epidemiologist, I hope you'll be able to look at that data and see that smoking is predominantly a male risk behaviour. And that kind of data exists. You have to find, you do actually have to dig quite hard to find that data aggregate for the world, but it's there, and as academics we can find it and make those kinds of slides. Similar data exists for alcohol use disorders. This is the outcomes of using alcohol. where what you've got, the line represents is essentially if males and females had exactly the same rate of alcohol use disorders. This data is from our World in data, based on WHO data. If males and females had the same risk of an outcome, they would sit on that line. But what you see in every country in the world is that alcohol use disorders are more common in males. And we can come back to that. I will come back to the question of alcohol a little bit later. But you'll see that when you disaggregate data by sex or gender, you can start to see patterns emerge, in this case, risk exposures. You can go one better and start to think about, well, how does this relate to gender equality at national level? And that kind of analysis has been done only a couple of times within the global health literature, but here's a pretty well-known paper from Hitchman and Fong, more than a decade ago, looking at the relationship between gender empowerment as measured at the national level through a constructed index from UNDP and what's called the smoking prevalence ratio, in other words, the ratio of male to female smokers. And what you see is the closer you get to gender equality at national level, the smaller the gap between male and female smoking. So as countries become more developed and move towards more gender equality, lo and behold, it turns out that women start to occupy previously male spaces and take on what were previously male-held behaviours. Whether that's smoking, you could actually do a very similar analysis and show a very similar thing for alcohol. You start to see the same kinds of patterns emerging for other previously gendered risk exposures. Right now, people dying on the roads are in a country like India, where I was last week, are predominantly men, because it's men who drive trucks, it's men who drive buses, it's men who drive tuk-tuks, it's men who drive motorcycles. Once you have equality in terms of who's driving, then your risk of dying in a road accident becomes more equalised. It's kind of as simple and as complicated as that. But this is showing you what you can do when you've got data that's disaggregated and you start to think about you start to think about sex and gender as being related to the exposures that make people sick in the first place. And where this ends up over the course of the lifetime of a life course is that in every region of the world, women will outlive men. Now, I'm not going to stand here and try to estimate what proportion of that difference is down to biology and what proportion of that difference is down to behaviours. Other people have done that, and they come up with varying levels of difference. But it's thought that, for example, about 30% of that difference can be explained in many countries with high smoking rates. It's down to men smoking, explains about 30% of that difference consistently. But these are the kinds of data points that we see in global health. So we get these sort of little snippets of being able to explain what we mean by male-female difference, what we mean by gender, what we mean by sex. But what Virginia and Angela have been working on in conjunction with us in Global Health 50/50 is trying to understand that along a pathway that goes from exposure to outcome, but also includes the impact of the health service. Because one thing I haven't shown you up till now is, well, what are health systems doing? You'll have noticed from Angela's bio sketch of me that I work in public health, and in public health we like to say the health system is important, but it's not the health system that's going to reduce your population mortality. The health system is there to treat people when they're sick. The contribution of the health system to reducing all-cause mortality is estimated to be somewhere between about 15 and 30%, depending on where in the world you are. Most of reduction of all-cause mortality comes from public policy. It comes from stopping people smoking or reducing exposure to alcohol or improving driving rates, etc. It's not to say the health system doesn't matter, but it's not the thing that really reduces all-cause mortality. However, for some conditions, the health service clearly does matter. Access to antiretroviral drugs if you're HIV positive is clearly the thing that is going to keep you alive and well. And what these pathways show is that if we look at who's got HIV, who is aware because they've been tested, who gets treated, and who is virally suppressed, again, we start to see quite big differences between men and women. This pathway is in Kenya, and we start to see what we see in almost every country where we've got this data is that men fare worse from the activities of the health sector. And again, we can come back to why that might be the case in the question and answer session. But we're only able to find those kinds of differences if we start to think about health along a pathway, but more importantly, if we start to think about gender data that's disaggregated. Here's a similar kind of pathway analysis for dealing with hypertension in China. So we've got 3 diseases that your colleagues have been working fiendishly on and struggling to get the data from WHO on for the past year, HIV, hypertension and diabetes. And I'm sure that there'll be an opportunity for them to present that data set in full when we've got full analysis. But what I think you might have noticed is you may not have noticed, but in most of the data points I've been showing you so far, we've talked about male and female. Now, for those of you who don't have English as a first language, the common understanding is that male and female refers to sex. You have a male dog or a male plant. You don't have a man dog or a man plant. So male, female refers to biological sex, whereas man, woman refers to gender and beyond man, woman, which again I will come to in a moment. But are we really measuring people's biological sex? Well, one of the activities that we've been doing recently, again with Angela and Virginia, is to say, well, what are people actually out there measuring? How do we know that's a sex difference and not a gender difference in all of these massive, huge surveys that involve millions of people all over the world? So we've looked in detail at 8 global health surveys. We don't find a single survey that tells us the definition of what sex means or what gender means. And what we see is a whole mishmash of what these surveys are reporting. Some are telling the enumerators to look at somebody and tell and record what their sex is. Others are telling the enumerators to look at somebody and say what their gender is. Others are allowing people to self-identify. I think, interestingly, it's the school surveys amongst young people that allow self-identification, but nobody else is allowed to self-identify. The other thing that I want to point out from the work that we've been doing elsewhere is looking at a variety of papers published across 12 health journals. So the previous slide, that was about big data sets. That's national and global. Well, in fact, this was all global surveys, the sort of demographic and health surveys that some of you might be aware of, for example. But we've looked at published papers in the research domain, 12 journals in health and medicine, where you'd kind of imagine that knowing something about sex and gender would be an absolute prerequisite for publication. And what we see is that there is no description of sex or gender beyond a binary in more than 99% of published research papers. So health researchers, who you would imagine would think more widely about sex and gender, don't actually put that into the data sets that they present inside their papers. And I think this is the slide that really tells us something about what the problem is that we've identified as part of the Commission. We looked at the first 1,000 publications that came out during COVID-19 in the health field. And what we found was that, that a very large proportion of the papers do talk about sex and gender, sex or gender. They will tell you, usually in table 1, the demographic characteristics of the population that they're looking at. How many men, how many women. But that's it. After that, if you get to the right-hand side of the slide, where we're talking about interpreting and analysing why you might see difference, that disappears. So we know who's in studies, but we know that there's a difference if you look at the data on whether we see a difference. Researchers observe a difference, but they don't then come back to that in their analysis, in their interpretation, in their conclusion to think, why are we seeing that difference? What's going on? So the bottom line from the Commission is that the health community frequently conflates sex and gender. It rarely, almost never defines what is meant by sex and gender in their surveys, in their studies, in their research. Has an incredibly binary vision of what sex and gender represents, and almost never goes on to explain why we see a difference. The next bias that we see is that in the health community, if I say the word, now, all of you, I'm sure, read the newspapers as much as I do. You'll know that if Donald Trump hears the word gender, somehow he hears transgender bathrooms. If Oban hears the word gender, somehow he's talking about or hearing homosexuality. It turns out, if you say gender to somebody working in global health, what they hear is women and girls. They have this completely narrow vision that we're just talking about women and girls. And we're not talking about any old woman. Well, we're definitely not talking about any old woman. We're only talking about women of what's called reproductive age, in that charming distinction that global health likes to consider women from 15 to 49. I always thought 49 was pushing it a bit, but anyway, 15 is also somewhat suspicious. But global health is concerned with women of a particular age group and a particular framing of what being a woman means. And generally in global health, what being a woman means is you're vulnerable. The first sentence, the first quote that I've got up here, for me really encapsulates part of the problem. Women are basically classed as the same as children. Women, children, and other vulnerable groups. We're completely infantilized within the framing, within the language, within the descriptions, the visual imagery that is used to talk about women and girls, particularly if it's women and girls from sub-Saharan Africa. And I'd really encourage you, if you've got time, to look at a beautiful essay published in Granta that is called "How Not to Talk About Africa." And I always think actually you could use the same essay to say how not to talk about women and girls. But global health does talk about women and girls as being vulnerable or having degrees of vulnerability and hence needing to be targeted. Now, what you see on the bottom quote there is national guidelines from the government of Kenya, where again, exposure to alcohol, in other words, who drinks, is predominantly a male activity, but the government, when designing its alcohol policy, says, well, let's target women. And what it really means is let's target pregnant women. In contrast, I did a quick Google search on men health. So this picture is not one of ours. This is Googling Women Health Africa, and this is the first image that comes up. This is the first image that comes up if I do Men Health Africa. It's an advert for a Men's Health magazine. But I think it speaks to something, again, that we have charted within the Commission. Men are framed as being responsible for their own health. It's as if the entire social determinants of health framework, which is otherwise used to explain health outcomes and ill health vulnerabilities within the global health sector, gets completely thrown out the window if what we're talking about is men. Men are suddenly the person. It's like neoliberalism suddenly becomes applied only when we're talking about men, because men are responsible for their own health behaviours and their own health outcomes. And more than that, men are generally responsible for women's health outcomes too, is the framing from the global health community. So where does all that lead us? Well, one of the things that we've done in Global Health 50/50 over the years is look at who benefits from the activities of 200 global health organisations across the sector. This is data from 2020. It's only 174 because some of them were UN agencies and we don't apply the same analysis there. But what we see is that so this is 174 organisations that are service providers or thought leaders or funders within this very complex sector that is global health. And the entire, if they've got a focus, if they've got a population focus, it's on women and girls. There are only 3 organisations that say they specifically target men and boys, despite all of those data points that I showed you at the beginning. There are 5 times as many organisations saying that they target transgender and non-binary populations compared to men and boys. The third entrenched bias is that gender is mainly irrelevant. And I'm just very quickly going to walk you through some analysis that we did as part of the COVID work in Global Health 50/50 that Angela referred to. We did indeed set up a data tracker. We ended up collecting the sex disaggregated data on COVID for every country in the world every week and published that for about 18 months. And we came up with this as a kind of final analysis of that data. And it showed that for every 10 women, fewer men get tested. 8 men get tested for every 10 women. Completely fits with everything we know about men's healthcare seeking behaviour. If this was about diabetes, fewer men would go and get tested. If it was about hypertension, fewer men would go and get tested. They are just as likely to be diagnosed as a case. They're more likely to be hospitalised. They're more likely to be admitted to ICU, and they're more likely to die. So there are these differences that need to be understood and accounted for, and we can certainly explore why those differences are there. But what I really want to show you is what happened when we analysed the availability of gender-responsive policies. So we looked in detail. WHO had 6 interventions that it recommended every single member state should be undertaking to control COVID. So we analysed 76 countries across the world to find out the extent to which those countries took gender into account in those 6 policy areas. And more than 90% of countries' policies that we analysed had no mention whatsoever of sex and gender. So I showed you the data at the start. I mean, at a global population level, having 20% gap between men and women getting tested, having a 30% mortality gap between men and women, one would somehow imagine that a policy might want to take this into account, but they don't. And these are the countries that you can see a couple of countries that were acknowledging gender, Canada and India being a couple of them. Okay, so how did we end up here? The Commission has now moved on from, okay, this is the problem, to thinking about what led us here. We've been a very multidisciplinary commission, not just epidemiologists, you'll be glad to know, political scientists and historians and lawyers, social scientists, a whole multidisciplinary look at why are we in this situation of misunderstanding what gender means. And we think there's a few things for us as a global health community and as an academic community to think about. One is the continuing impact of where the global health system came from. And it came, of course, it arose from the colonial health systems of the 19th century, which for all of the historians amongst you will know was an incredibly racialized and gender misogynistic health system, which continues in some forms to this day, including in the structure of healthcare professions. This is a picture of Florence Nightingale, who's often seen as the architect of the nursing profession in the 19th century. And Florence Nightingale really, really strongly believed that men couldn't and shouldn't be nurses. And in countries I've worked in, by law, only 10% of nursing graduates are allowed to be male. So these ideas, these notions of who constitutes, who is allowed to occupy different parts of the healthcare system professions, they continue to this day, based on the historical legacies of the 19th century. The other thing that we see really continuing through the global health system reflects what happened post-Second World War, into the Cold War, into the kind of the rise of American imperialism in global health, is an absolute focus on population control. So as a system and as a sector, we have struggled for the past 30 years to move ourselves away from being just focused on being providers of family planning to being providers of comprehensive health services. But in many low and middle income countries, if you look at what constitutes comprehensive health services at the primary healthcare level, the lowest level of the health system, the village level or the small town level, it's maternal and child health and family planning. So ministries of health have been focused entirely on questions of population control for decades, usually financed by American money or money that has come through the multilateral system from the Americans to dictate what the priorities of individual countries, such as Bangladesh, which is why I've got a picture of Kissinger there. And the global health sector is still struggling to shift itself out of that focus just on women. The other area that is really controlling what we, or manipulating and exploiting what we understand to be gender within global health right now, is the commercial sector. So I showed you those two slides about exposure, which were exposure to commercial products, the products, health-harming products. And we've seen over decades that the commercial sector has used gender norms and gender stereotypes and gendered imagery to sell their products. This is the move towards female-friendly alcohol drinks, which are sweeping across large parts of East Asia and South Asia at the moment. And we know that the tobacco companies, for example, have departments entirely dedicated to expanding their markets amongst women in Asia and Africa, based on, again, decades of experience, literally since 1929. The targeting of tobacco products to women as an emblem of empowerment. You've come a long way, baby, was not designed, didn't arise out of nowhere. It's that merging of the notion that to be an empowered woman means to be a woman who smokes, that is still at the basis of a lot of the marketing used by the tobacco and increasingly the alcohol industries today. And finally, in terms of the why we are where we are, we're where we are because it's become increasingly difficult, particularly over the past decade, to move forward, because we've got extraordinarily powerful interest groups, religious interest groups of all religious persuasions, political interest groups, merged against progressive gender ideologies in a whole host of countries. I mean, you know, it would be hard anywhere in the world in an audience like this for people not to know about Roe versus Wade and what that represents in terms of a gender ideology pushback. But we see this argument and the power of that argument everywhere. We see that in Hungary there is closing down of departments of gender studies. We see people trashing Harry Potter books because there's a debate over an argument over transgender ideologies and transgender identities, focused on whether we're talking about gender or whether we're talking about sex, that is being spearheaded in Scotland right now, with J.K. Rowling pitted against the Scottish government, for example. And we see a coalescing, the bottom right-hand picture represents a march where it was a coalition of Islamic and Catholic groups in the US, essentially calling for the closing down of libraries that were providing books on gender identity to young people. So we know that we're dealing in an incredibly political space. It's not just a space where data is what matters. It's a space where ideology is what matters and is what is dictating the rules of the game. And my final slide really is a point of saying that as an academic community in global health, we have singularly failed to take a comprehensive and holistic view of how we understand health in general, but particularly how we understand gender and health. We've taken a view that's incredibly positivist and empiricist, and it needs to be measured and counted, even though, as I've shown you, there's a complete misunderstanding as to whether we're counting sex or whether we're counting gender. But what we have singularly failed to do, particularly in schools of public health, is have a multidisciplinary vision of how to understand and interpret what measured differences mean. We don't find historians generally in schools of public health. We very rarely find lawyers in schools of public health. We have no way of actually interpreting why those differences are there and what they might, how we as a community might start to reduce those differences. I had a couple of slides on leadership. Angela's given you the headlines on those. So just my recommendations. These are the recommendations from the Commission. These are the recommendations for the research community, and this is the health research community. Perhaps it's different if you're all from education or law or finance or any other community, but for a community that is about the human body, there has been a remarkable lack of understanding of what we're talking about when we're talking about sex and gender, and we don't tell others what our terms mean. So this slide essentially tells you what our key recommendations are. We want to know what your terminology is. We want to know what it is you're talking about. We want you to move from table 1, telling us who's in your study, to actually interpreting and analysing in your discussion and conclusion. And we want you to break down disciplinary barriers and hierarchies where epidemiology is all that matters, or economics is all that matters, and take a much more holistic, multidisciplinary view of how to understand difference. And this is where we've come to. You remember the slide I started with, the one line from WHO. And we've got a revised definition that's still a work in progress, but essentially it's a definition that recognises that whilst identity is an important part of understanding gender, what gender really represents is the political notion of who holds power. And that power is distributed on the basis of gender, not just in terms of what our individual gender identities look like or feel like, but is absolutely embedded in every system and structure of society. And so if we want to really address gender inequalities, we need to take a political and structural approach to breaking the norms, the gender unequal norms of systems and structures. And it's only with that we can move from understanding gender to achieving gender justice. Gender justice where gender differences don't create gendered disadvantages. And we're addressing the systems and structures, including through upholding the universal human rights of everybody, and including through diverse leadership and recognising rights of participation for everybody, irrespective of what their gender identity is. Thank you.
Okay. Thank you, Sarah. Now we open up for questions and comments. Yes.
Hello. So, in asking for this more direct language and asking for researchers to push policies which address gender directly, it seems like you're asking researchers to engage in political antagonism with some of these groups you've brought up and with governments themselves. Are we equipped to do that? And if we are not, how do we become equipped to do that?
That's a really good question. And I'd love to hear other people's ideas about whether we what I've heard you say is, should we be doing it, and then how do we do it? Are we equipped to do it? My own view is that nothing about research is politically neutral. Making a decision, if a government makes a decision to fund research, that's a political decision because that money could be going elsewhere. Nothing we do is within a politically neutral space, and that political spaces are, by their very definition, just like research spaces, gendered spaces, because there isn't any system or structure in any society that is somehow gender neutral. And part of, what I teach is the politics of decision making in global health, and part of understanding the politics of how decisions get made is understanding the role of vested interests, which is part of what you've seen here. Vested interests of anti-gender groups, vested interests of the commercial sector. Personally, I think we cannot ignore that. Because if we ignore all of that, if we decide we can't take that on as people working for gender justice, we're never going to succeed. We're always going to fail, because those groups, the last time I looked at the profits of Philip Morris and British American Tobacco and one other big tobacco company, their profits were $37 billion a year. The operating budget of WHO is $2 billion a year. We're never going to win a fight we're never going to achieve gender justice unless we realise that we've got a fight on our hands. So we have to be open about it. The question as to whether researchers are best placed to take on that fight, I think calls into I think it's really hard to generalise, but certainly what we do, by we I mean within my group within UCL and Global Health 50/50, is we operate within advocacy coalitions where we recognise we're not necessarily the best placed people to design a placard or get a letter writing campaign, but we work with the NGOs that do that. So we actually, if you're interested in the theory of advocacy coalitions, I'd suggest you look at the work of John Gaventa, who's at the Institute for Development Studies. But it's kind of a well-recognised way of saying one discipline, the academic discipline, can't change everything by themselves, but the power of societies working together is what can make a change.
Yeah, thank you very much, Mustafa Qasim from Medical Faculty. I wonder whether what we are seeing of gender inequality has a background in economical inequality within countries and across the world. And if we try to address this problem, some of the issues that you've been referring to will be dissolved by themselves?
Yes, certainly. I mean, the measure of what constitutes gender inequality is a composite. So this is this kind of globally agreed measures that are currently in existence. It is a composite index that incorporates economic features, political features. So you might have pretty good gender labour force participation in a country like China, for example. But you haven't, when you look at those pictures of the Chinese Politburo, you don't necessarily have political equality or equality within decision-making spaces. So the index incorporates economic, political, some educational, I think. Is that right? And a couple of health factors as well. So it is very recognised that economic inequalities are, or economic equality is part and parcel of achieving gender equality. But you know, some of those that Hitchman and Fong slide that I showed you that was the relationship between gender equality and smoking prevalence ratios, I think is where what we're trying to caution awareness of in calling just for gender equality without thinking about health equity as well. Because quite honestly, if I worked for Philip Morris, I'd want gender equality because I'd want to double the size of my market in Africa. So just having economic equality without thinking about health equity, we're saying is not sufficient.
Thank you so much, Sarah. That was wonderful. You tore away some wheels in front of our eyes, I think, even for me who has worked in global health and also been interested in gender issues. So it was a wonderful presentation. I have two questions for you. One of them being in relation to maybe to Lancet. I don't know how close you are to their editorial policies, but I know that there has been a push, among others, from the Organization for the Study of Sex Differences for many years now to request journals to actually ask for disaggregated data. I don't think we've come very far, not judged on what you showed us also on your slide. What can be done to promote this even more? So that was one question. And the other one, a very Danish one, where we are currently discussing quotas, quotes of women on boards, etc. So I'd like to hear if Global Health 50/50 has any policy on our opinions on that aspect.
So we have raised that question with the Lancet, and in fact we did one year in Global Health 50/50, we looked at the editorial policies of I think about 12 journals, and found that actually only one journal, that these guidelines for taking account of sex and gender all the way through your research outputs come under something called the SAGER guidelines, and we only found one journal that incorporated the SAGER guidelines in their editorial policies. In other words, you were supposed to not be able to get published if you didn't incorporate the SAGER guidelines. So in fact, I have had that conversation with the Lancet, and what they say is that they are, as a publisher, they're the end of the chain. And actually it's up to us as academia to get our house in order, because if they start imposing those policies at publication, but nobody's doing the research that's taking sex and gender into account, then essentially they won't have anything to publish, I think was where they were coming from. So what they're essentially saying is that the entire academic ecosystem needs to get its house in order, not just the publishers. And part of that is working with the funders as well. So I know in the UK, for example, there's a lot of conversation goes on between the funders and the universities in terms of how equity issues are addressed in research funding, because we can't rely on the journals to do it. And in terms of what GH 50/50 does, what we're trying to deal with is this. This is a photograph on the 7th floor of the old WHO building, so which is the upper echelons of the building, and it's the head of the World Bank, it's the head of WHO, it's all of their senior people. Now, you know, I've just critiqued doing observations of gender rather than asking people to tell you what their gender is. But I would defy anybody to look at this photograph and not see a problem. And when I actually presented this at WHO, what I got was, oh, but if only it was a wider angle camera, you'd have seen a couple of women sitting at the side. It's like, well, yeah, I'm not sure that actually makes it any better, if I'm honest with you. And so what we've seen over consistently, this is 3 years of data, but we've got 5 years of data, 70% of the leadership is male, 80% from high-income countries, and 90% educated in high-income countries. So as Global Health 50/50, we are consistently putting this data out to say there is a problem. And as Angela said, when it came to board seats, there's an even bigger problem. Our response to this, we've been taking an advocacy coalition approach. We've been working with a group called Women in Boards, Women on Boards, to try to understand how do you change that. And it really has to be changed at the policy level. It needs to be that every board needs to say we want representation, not just on the basis of gender, but on affected communities and other characteristics, because otherwise you just end up with the same people thinking the same way, making the same set of decisions.
Any other question? I would like to challenge you a little bit on this topic, because you showed us some statistics that as women equality increases, they adopt male behavior. So by having affirmative action, for example, in these boards, having more women doesn't necessarily mean that they will bring a kind of a gender-neutral perspective, because maybe they will adapt already behaviors and attitudes present in this board. So what do you think about that?
I think, look, I grew up under Margaret Thatcher. I am absolutely, and you know, I think, to be honest with you, I was saying this to Angela last night, to be honest with you, I'm not sure calling ourselves Global Health 50/50 was actually necessarily politically smart. But the cost of rebranding it sounds really very high. I don't think that this is about believing that you simply change the gender makeup of leadership. What you need to change is the mindset. And I am much more in favour of saying what you need is feminist leadership. And that means anybody can be a feminist leader, because it's the principles associated with feminist leadership that matter. That's not to say that diversity and equality at the level of decision making doesn't matter, because all of the evidence shows us it does matter. There's plenty of evidence from the commercial sector as well as evidence from the health sector to show that if you've got diversity of leadership, you actually have better outcomes from the activities of the sector. That, you know, this is what Esther Duflo got her Nobel Prize for, right? Was showing that if you had female leadership in the politics of the political structures of West Bengal, then you actually had measurably better maternal and child health outcomes in the villages where you had female leadership compared to the villages where you had just male leadership. Because women do make decisions in politics that are different to the decisions men make. They make decisions, what Duflo's work showed was that they make decisions to put more money into social services, social sectors, education, health, etc., caring services, and that had a measurable outcome on health. And in the commercial sector, what we see again and again is commercial companies making arguments about profit margins are higher when you've got more board diversity. And they you know, there's plenty of evidence shows you the data there. But I certainly wouldn't encourage anybody to walk away thinking that just appointing a bunch of women is the panacea. That it needs to be about, it's a different way of thinking about systems and structures. That's the justice part of it.
Last final quick question.
So thank you. I am Virginia. You heard from Sarah. I've been collaborating. Can you hear me? Yeah. So I am a demographer, and Sarah knows this. I just would like to point out to the fact that the relationship, gender equality or inequality, and economic, socioeconomic inequality or equality, going back to the point that you made earlier, it's really not straightforward as we can think. As a demographer, I know that Japanese women are the leaders in life expectancy. They live longer, they are the healthiest on average. And yet, Japan is probably one of the most traditionalist society. And if we reason just in terms of increasing gender socioeconomic inequality, would not necessarily act on the dimension that might actually increase gender equality or inequality in health. Also, what does it mean, gender equality or inequality? Does it mean that we want to bring both the men and women to have the same life expectancy, but that would be unfair towards the sex that now has a higher life expectancy? Or do we want to bring, you know, I mean, it's really complex, and there is absolutely no single dimension that we are sure we can act on. Also, Sarah, I thank you very much for this great presentation. Another big point, major point that I think it is lacking in the global health debate is exactly what we discussed already a few times, the age dimension. We talk about gender, and I mean women, gender, health, equality. Everybody often we think about women in reproductive ages. That's it. That's the window. But, for instance, gender differences in survival or health are very different across the ages. And nowadays, more and more women live longer and survive past the reproductive ages. So we want to increase survival and health of women in the reproductive ages. But what happens afterwards? They have completely different. Every age group has completely different needs. So the need for disaggregated data is for disaggregated data by sex or gender, or both, and age. Because if we go along, we have this pathway work, we have it also by age. And there are clearly different needs in each age groups and different patterns that we see. So this was just to say that it's very complex. It's not really as straightforward as some people might think. Sarah knows that is not easy and simple. I just wanted to bring this debate into this idea of the age difference and the complexity, and it doesn't really go from one direction to the other. It's both, and we don't even, depending on which outcome we are focusing, it can even be reversed. We might even need to work to increase men's health sometimes, depending on which outcome we are looking at. Thank you.
Sarah, any final words before we wrap up?
Just a huge thank you for sitting through this and for your comments and questions. And I really would be delighted if anybody had any comments about what we should be doing differently or something else we might want to think about as a commission before we go into the Lancet peer review process. I'd be very grateful to hear from any of you. Thank you.
And we'll
Thank
be
you.
at the DS lunch, so if anyone is interested in joining, please continue the conversation. Thank you very much.
Thank you.